You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for March 13th, 2026. This week, some listener feedback, beta blocker use in non-obstructive hypertrophic cardiomyopathy, a head-to-head Apixaban versus Rivaroxaban RCT, a observational study of Diltiazem versus Metoprolol when combined with direct-acting oral anticoagulants, and accuracy of smartwatches for atrial fibrillation. First, some feedback. Dr. Daniel McIntyre writes to me from Sydney, Australia about my coverage of the EMPATIC trial, which tested guideline-directed medical therapy in patients who had heart failure and advanced cancer. Not surprising was that medical therapy had no effect on a primary hierarchical endpoint that I actually loved and I want to repeat. This was a combination of 1, days alive and able to wash oneself, 2, ability to walk 4 meters, and 3, a patient-reported global assessment of just well-being. I highlighted the study because you would not believe how many very ill patients, not only with cancer, but other conditions like dementia, COPD, end-stage renal disease, frailty, who, instead of prescriptions for cheeseburgers and ice cream, get 4 drug therapy for heart failure. Dr. McIntyre read the study carefully and noted that most patients in the study with heart failure actually had HFpEF, and only one of the selected medicines has the backing of an RCT, and that's empagliflozin. But I would note that sacubitril valsartan came close in HFpEF. But McIntyre writes that this is important because in this population, his approach has been to prioritize diuresis for symptom relief over RAS inhibition. It was a shame to see, he said, no patients randomized to MRA or even furosemide. He notes that only 40% of patients in both arms were on these medications, and I agree with this concern about MRAs. I think MRAs are highly effective, and I lean towards the sub-analysis of the TopCat trial, which excluded Russia and Georgia and showed a large benefit for spironolactone in patients with HFpEF. I call MRAs or spironolactone my secret weapon for these patients. But in a patient with advanced cancer or other severe diseases, simply preventing congestion with loop diuretics might be the least disruptive and most effective thing. All right, first topic is beta blockers in non-obstructive hypertrophic cardiomyopathy. Now, when I discussed this study of beta blocker versus calcium channel blockers in patients with non-obstructive HCM, with a number of my friends in academia, they said, John, we've known for years that beta blockers impair exercise capacity. Which I thought was kind of funny because almost every patient I see who has any degree of hypertrophic myocardium of any sort is on a beta blocker. It's like the sky is blue and patients with HCM take beta blockers. And guidelines still give beta blockers or calcium channel blockers a class 2A recommendation in patients without obstruction. Yet there are no RCTs in non-obstructive HCM. Beta blockers and calcium blockers were established in patients who had obstructive HCM, and this is likely a very different condition. Well, Jack has published a very nice crossover double-blind RCT of bisoprolol versus verapamil in patients who have non-obstructive HCM. A group in Aarhus, Denmark, conducted the mainly exercise capacity trial. Now, whenever I mention Aarhus, Denmark, I fondly remember my visit there a couple of years ago when a group of very young people took me on an 80-kilometer bike ride in the hills and along the sea. And it turns out that you just can't sit on wheels in Denmark. This is a very hilly country, at least in the north. Now, the goal of this trial was to assess the peak oxygen consumption, PVO2, as well as exercise response, symptoms, biomarkers, and structural changes on the 2 drugs. 32 patients, now that sounds small, but 32 patients were randomized, and they underwent a crossover, so each patient was actually their own control. There were 1-month sessions on bisoprolol, and then they had cardiopulmonary exercise stress test, then 1 month washout, then 1 month on placebo and testing, then 1 month on verapamil, and then the stress test. And each patient served as its own control. Patients were blinded, investigators were blinded. This is actually a 3-stage trial, and this report is stage 1, the exercise part. Stage 2 and 3 will look at myocardial remodeling and arrhythmias, respectively. These were young patients, 54 years old, 34% female, and half had a pathogenic mutation. About a quarter had an ICD. Okay, the main finding was that the PVO2 was 25.7 milliliters per kilogram per minute with bisoprolol, 28.2 with verapamil, and 28.7 with placebo. So when comparing the differences of the combination, bisoprolol versus verapamil, bisoprolol was minus 1.8 milliliters per kilogram per minute, which was statistically significant. Bisoprolol versus placebo was even worse, minus 2.5, and here the p-value was more significant. Verapamil versus placebo was not significantly different. Peak heart rate was lower with bisoprolol. Neither bisoprolol nor verapamil changed the oxygen consumption at anaerobic threshold or the minute ventilation over CO2 production slope. Bisoprolol worsened the KCCQ questionnaire while verapamil did not. Bisoprolol increased the BNP while verapamil decreased the BNP. My comments. I see this as an elegant demonstration that beta blocker clearly worsens exercise capacity and has negative effects on other outcomes relative to verapamil and placebo, such as quality of life and BNP. Now, you could go on and on about why beta blockers worsen exercise capacity, like things like blunting of the heart rate, or maybe it's the negative inotropy. But I don't think the why question matters. Here, you have evidence that is clearly worse, and there's no other data to support beta blocker use in non-obstructive hypertrophic cardiomyopathy. So, in the absence of reasons to use beta blocker, like atrial fib with a high ventricular rate, in these patients with non-obstructive HCM, I think this study strongly suggests that we should avoid beta blockers. Now, some may say we already knew this and this study was not necessary, and I don't know. I don't think so. I see tons of patients with HCM who take beta blocker for no obvious reason. It's like one of those dogmas that persist, like the aspirin for prevention dogma, and I think it needs widespread reversal. As for verapamil, it was better than beta blocker for sure, but it was no different from placebo. So again, in the absence of symptoms, I don't see any reason to use beta blocker or calcium blocker. But if there were symptoms in these patients, say palpitations or maybe dyspnea on exertion, verapamil would clearly be better than beta blocker. So I say good on the OHU's team. This is an excellent study, and I look forward to stages 2 and 3. All right, next topic is Apixaban versus Rivaroxaban for bleeding risk. Now, you, like me, have probably wondered about the superiority of these two drugs. In our neighborhood here in Louisville, the two drugs are basically used interchangeably, almost at random. Rivaroxaban is once a day, which is a huge advantage regarding compliance, and Apixaban has the strongest data against warfarin in the DOAC versus warfarin trials. And its BID dosing with lower doses gives an impression of maybe smoother levels without the spike in anticoagulant effect. This week, New England Journal of Medicine has published a head-to-head comparison of the two drugs, not in patients with atrial fibrillation, but in patients with VTE and PE, which is a bit different. Now, Canadian, Australian, and Irish investigators conducted this open-label pragmatic RCT. There was no role of industry. VTE and PE treatment is different than AFib in that both drugs are loaded. They have a loading phase. And actually, this loading phase may be important for trial interpretation, so stay tuned. More than 2,700 patients were randomized in one-to-one fashion. Apixaban dosing was 10 milligrams twice daily for a week, followed by 5 milligrams twice daily. Rivaroxaban was 15 milligrams twice daily, not for a week, but for 3 weeks, followed by 20 milligrams daily. And I think that's an important distinction, 1 week versus 3 weeks of loading. The primary endpoint of this trial was clinically relevant bleeding, which was a composite of A, major bleeding, or B, clinically relevant non-major bleeding. Notably, this was only a 90-day trial. So a primary outcome event occurred in 3.3% in the Apixaban group and 7.1% in the Rivaroxaban group. That relative risk is 0.46, so a 54% reduction in major bleeding, and that is a highly statistically significant result. The absolute risk reduction was 3.8%, corresponding to a number needed to treat of only 36, or number needed to harm, actually, if you're going the other way, of 36. If you use the lower bound of 0.33, then the number needed to harm could be as low as 21. Now, the death from any cause occurred in 1 patient in the Apixaban group and 4 in the Rivaroxaban group, and that was too few events to make any conclusion. Serious adverse events unrelated to bleeding, such as venous thrombosis, occurred in 2.7 versus 2.2% in the Apixaban and Rivaroxaban groups, respectively, and that was not different. When you look at the Kaplan-Meier curves, had most of the separation by day 21. Then the curves were separating only by a small degree. Medication adherence was actually a bit better in the Rivaroxaban arm, as you'd expect. So my comments. The first thing to say is kudos to the Canadian, Australian, and Irish investigators. This is an excellent trial, and we need more of these kinds of studies. Observational data would struggle with this question because if clinicians, not randomization, chose the drug, then you would never know if there was selection bias. This data also aligns well with previous trials, though none have directly compared the 2 DOAC drugs for VTE. In the trial called Einstein, Rivaroxaban was compared against VKA, and it was 8.1% Rivaroxaban, 8.1% VKA, so no different. Not worse, though. In Amplify trial, it was 4.3% of the patients in the Apixaban group had bleeding versus 9.7% in the VKA group. So when you look at these 2 previous trials, Apixaban hugely outperforms VKA, but Rivaroxaban just had the same bleeding rates. But again, cross-trial comparisons are tempting, but you should resist the urge. That's why this head-to-head comparison is so valuable. When I first looked at the Kaplan-Meier curves, when it came across on social media, I thought, gosh, this is huge, and this is a crushing defeat for Rivaroxaban. But then I looked a little deeper, and now I wonder if the answer isn't simply a too aggressive loading phase, because most of the bleeding was early. It's hard for me to tell how these different loading regimens came to be. A quick look at the Einstein trial reveals that the authors seemed to make an estimate of what it should be. Now, I did not find a dose-ranging study or anything like that. On the other hand, I did find a dose-ranging study for Apixaban. I could be wrong here in the origins of these 2 regimens, but they're clearly different. And that means that there's an asymmetric exposure to higher doses of anticoagulation for 3 times longer in the Rivaroxaban arm versus the Apixaban arm. The loading dose seems like it may play strongly as a role because the difference in the primary endpoints came early. Not all of it was early, but most of the difference comes within 21 days. So, as always, there are 2 messages from this superb trial. Specific messages for these patients with VTE and PE, with these loading regimens, Apixaban is the superior drug because efficacy is similar and bleeding is substantially reduced by half. And the absolute risk reduction is also clinically substantial, with a number needed to harm from Rivaroxaban over Apixaban at 36. The larger message, though, is that trials like this can be done. It's well worth the government's money, in my opinion, to sort out these differences, as when you multiply this by millions of people treated, the impact can be huge on a societal level. The only caveat here, and gosh, there are always caveats, aren't there, is that what if the Rivaroxaban loading dose was only a week like Apixaban? Then would the 2 have been equal? Would efficacy have been similar? Now, I know there's a temptation to extrapolate this to patients with AFib. Millions more people are treated with these 2 DOACs for AFib than VTE. Should we also prefer Apixaban for patients with AFib as well? And I don't think so. The problem is that we don't have different loading programs in AFib. We don't load the drugs at all. What we do have in AFib, however, that's different than PE, is we have much longer treatment times. So if there were a small signal of higher bleeding risk with Rivaroxaban over Apixaban at this maintenance dosing for AFib, then it might be borne out in a 3 or 5-year study. And I think that study should be done, especially with this data. Now, it won't be done by the company, so it'll have to be done with government funding, but I think it's well worth the money and effort. Okay, next topic. There was actually another DOAC study to mention, and this one is really interesting. Diltiazem versus Metoprolol when combined with the DOAC. The Annals of Internal Medicine has this very nice observational study from a Vanderbilt team looking at the risk of bleeding in patients with AFib from concomitant use of either Apixaban or Rivaroxaban with Diltiazem versus Metoprolol. So the scenario is this. Your patient is put on a direct-acting anticoagulant. These days, it's either Apixaban or Rivaroxaban. Then they need rate control, and the choice is either Metoprolol or Diltiazem. And this is an everyday issue because we either use those two drugs for rate control. But here's the issue, though. Diltiazem is a potent inhibitor of cytochrome P450-384, and it's a P-glycoprotein substrate. Both of these features can affect the metabolic pathways of factor Xa inhibitors, and this could predispose patients with atrial fibrillation to higher levels of DOAC and serious bleeding complications. Metoprolol doesn't have these effects. So the authors wanted to compare bleeding incidence in patients who use these DOACs and take either Diltiazem or Metoprolol. Now, obviously, RCT would be best, but there is no RCT. So this group did a retrospective cohort review, and they used a large administrative healthcare database. They had a lot of patients, 23,000 patients on one of these anticoagulants who took Diltiazem, and about 85,000 who took Metoprolol. So these are not random comparisons. These were clinicians' choice. So the next step is they balanced the two groups with propensity matching, and they end up using 23,000 patients who on paper had similar characteristics. And then the patients were followed for a year. Their primary endpoint of interest was serious bleeding that required hospital admission, and of course that's available in the database. Now, the authors did some extra analyses, and one in particular that was important was a comparison of bleeding events on low versus high doses of Diltiazem. They also compared Apixaban versus Rivaroxaban, and I'll tell you more about that in a minute. So the main results, patients who took Diltiazem had an 18% higher rate of bleeding than those on Metoprolol. The 95% confidence intervals went from 1.02 to 1.37, so this is considered statistically significant. However, the absolute differences are going to be small. There were 34 versus 29 bleeding events per 1,000 patient years. Another way of thinking of that is 0.34% versus 0.29%. And that would translate to a number needed to harm of approximately 300 patients using Diltiazem over Metoprolol. They also found a dose response and that the risk for bleeding increased with high versus low dose of Diltiazem, which was broken down and dichotomized at greater than 120 versus less than 120 milligrams per day. The absolute bleeding incidence was 0.9% versus 0.3% high versus low. They also did a Rivaroxaban versus Apixaban comparison with Diltiazem, and it favored Apixaban. The rates of bleeding were 38.5 per 1,000 patient years with the Rivaroxaban Diltiazem combination versus 30 per 1,000 patient years with a Apixaban Diltiazem combination. This difference did reach statistical significance, but it was not the primary endpoint, nor did I see any testing for multiple comparisons. Now, the rates of stroke and systemic embolism were not statistically different. I think this is one of those rare, non-random comparison studies that we can actually make causal inference from, namely that there probably is more bleeding when using Diltiazem over Metoprolol. Why do I say this about this non-randomized comparison? For a number of reasons. First, the Kaplan-Meier curves do not separate immediately. It takes time or exposure to the separate levels. This suggests causation as longer exposure to higher Anticoagulant levels in the diltiazem group should gradually increase bleeding rates, and that is what was seen. Another suggestion of causation comes from the analysis of diltiazem dose. You'd expect a higher dose of diltiazem to have more blockade of the metabolic features and higher anticoagulant levels, and that should lead to higher rates of bleeding. And indeed, the absolute rates of increase of bleeding events was greater in the high-dose diltiazem group. And of course, dose response is one of those Bradford Hill criteria for causation. Another clue comes in the differential bleeding rates with Rivaroxaban versus Apixaban. It turns out that Rivaroxaban depends more on CYP3A4-mediated interactions than does Apixaban. When diltiazem blocks CYP3A4, Rivaroxaban levels are likely pushed up more than Apixaban levels. And again, bleeding rates were slightly higher with the Rivaroxaban-diltiazem combination than the Apixaban-diltiazem combination. Now, this was a secondary comparison, and confidence intervals barely excluded no effect, so caution is warranted, but it's directionally consistent with the drug-drug interaction effect. But I think the strongest evidence for causation is that the choice of metoprolol versus diltiazem is often random. Now, the drugs both slow the rate of conduction of AFib through the AV node. Now, there's a tendency to use diltiazem in patients with lung disease and maybe metoprolol in patients with coronary disease, but in the vast majority of cases, whether a person ends up on metoprolol or diltiazem is largely random. So, what should we do about this study tomorrow in clinic? My first point is that drug-drug interactions are real and they're underappreciated. We should be more mindful of drug-drug interactions. Of course, they come in two varieties, right? One type of interaction is pharmacokinetic, and that's what this is, wherein one drug alters the metabolism of another. The other variety of drug-drug interactions is pharmacodynamic, where the two drugs have additive effects, say digoxin and metoprolol. They interact because both slow heart rates. The second take-home is that a diltiazem DOAC combination probably does increase bleeding versus a metoprolol DOAC combination. The difference is tiny. It's less than 0.5% in absolute terms. The number needed to harm is 300. Most people on the combinations would have no effect, no difference. The absolute risk increase, however, may be significant in a population of hundreds of thousands, but on an individual level, it's very small. And so there are patients who feel worse on beta blockers. We see this every day. For these patients, diltiazem can work well. And so I don't see a problem with using the drug combination in the average patient. The one caution here, I would say, is that this was only a one-year study, so it might be an accentuated effect over 3 to 5 years or 5 to 10 years. I might also be concerned with diltiazem in patients who had an inherently higher bleeding risk. Let's say they were on antiplatelet drugs or they had low platelet count. In these patients, this tiny risk could increase, and you might be more apt to use metoprolol for rate control. And I think it's really nice for me to cover an observational study that gets very close to making causal conclusions because it's very rare. All right, next topic is on the actual clinical use of smartwatches. Europace has published an excellent study from the Circa-Dose trial investigators led by Canadian electrophysiologist and hockey star Jason Andrade. Their goal was to assess how 3 different AFib watch algorithms would stack up to the gold standard using implantable loop recorders. The study was doable only because of the novel characteristics of the original Circa-Dose trial. Circa-Dose was an RCT comparing 3 ablation strategies in patients with PAF, paroxysmal AFib. It was contact force RF ablation versus a 4-minute versus 2-minute cryoballoon ablations. The follow-up was 12 months, and it was one of the first trials to use implantable loop recorder monitors that allow calculation of AF burden. The other neat feature of Circa-Dose was that the more you monitor, the less successful AF ablation looks. Implantable loop recorders give a much more modest success rate than, say, intermittent Holter monitoring. So the main trial results published in Circulation in 2019 found no difference between the 3 strategies. They all looked similar. All three reduced AF burden, though I have to say AF burden was quite low in these patients to begin with. The study question for this EuroPace paper centered on how useful can consumer data be in making clinical decisions. So all patients in the Surgadose trial had loop recorders, so the research team used these to simulate smartwatch algorithms. Now, they did not have patients actually wear smartwatches. Instead, they used the continuous ILR rhythm data as a ground truth recording, then mathematically applied the sampling rules of each smartwatch algorithm on top of it. So basically, if a smartwatch was checking the same rhythm at its programmed intervals, what would it have detected? And these three algorithms that they tested were the Apple Watch AF burden algorithm. That was simulated by sampling the ILR data in 1 minute windows every 15 minutes between 8 a.m. and 10 p.m. Then they would just calculate what fraction of those checks showed AFib. The second algorithm was the Apple Watch irregular notification algorithm. This checked every 2 hours, and if AF was found, it switched to every 15 minutes, triggering an alert if 3 of 5 consecutive checks were positive. And they also checked the Fitbit irregular heart rate algorithm. This required 11 consecutive 5-minute checks every 2.5 minutes to all show AF before generating an alert. Now, while this simulation likely overestimates real-world smartwatch performance, because often the PPG signal is less than ideal, and also patient compliance was assumed ideal, the research team argued these were still reasonable estimates, and I agree. Overall, the watch algorithms did very well. For AF recurrence detection, the sensitivities of these algorithms versus the loop recorder were 82% for the Apple Watch AF burden, 71% for the Apple Watch irregular notification, and 64% for the Fitbit irregular heart rate determination. All three wearables, however, outperformed or equated conventional intermittent monitoring with up to 3 14-day ECG patches. How did they do for AF burden estimation? The correlation for all three algorithms was superb, 0.97 to 0.99. And AF burden in missed detections was clinically negligible, so less than 0.02%. The effective wear time. Sensitivity of these things improved substantially with longer daily use, and it rose from 42 to 50% if they wore it 1 hour per day, up to 82 to 90% for 15 to 24 hours per day. But get this, even 1 hour a day of watch use outperformed 3 repeated 7-day Holter monitors. Patient activity did modestly reduce sensitivity from like 82 to 64% with no activity to 71 to 50% with high activity. And finally, nearly all missed recurrences had extremely low AF burden. Virtually no patient with greater than 0.1% AF burden were missed by the Apple Watch AF burden algorithm at standard wear times. So my comments, again, I want to emphasize again that this is a best case scenario because it was a simulation study of the algorithm using very clean data from the loop recorder. The data from the wrist is not so clean. But this study shows A, smartwatch algorithms outperform conventional non-invasive monitoring that we do in the clinic. B, the Apple Watch AF burden algorithm seemed modestly better in terms of sensitivity than the other ones. C, AF burden estimates are strongly correlated with the AF burden estimates from the loop recorder. D, missed detections are likely clinically insignificant. And E, longer wear times improve performance. And overall, I think this is a really important paper because many more patients wear these devices. And we now have 2 trials, OCEAN and ALONE AF, which suggest interruption of anticoagulation may be reasonable in patients who do not have AFib after ablation. So when these smartwatches came to be, I was highly critical and I was worried about false positives and overdiagnosis, and I still am, especially when they're deployed in young, healthy people who do not have AFib and have a low incidence of AFib. Because remember, if you deploy a screening device in a low incidence condition, you're going to have mostly false positives. But this study, and also my clinical experience in AF clinic, reveal a possible role of these consumer techs in actual decision making. For instance, you ablate a person who had symptomatic AFib, Maybe even they have a CHADS VASC of 3, 4, or even 5. These patients had, before the ablation, reporting many episodes of AFib. They felt their AFib, and then then they had watch notifications pre-ablation. Now, this patient is 6 months after ablation, and they report no symptoms. Doctor, I'm fixed. Every ECG you do in the clinic shows sinus rhythm, and then they tell you their watch shows no AFib, whereas before it was showing AFib. Week in and week out, the watch notifications are negative. So in this case, your pre-test suspicion is that their AFib is gone. The data from the watch strengthens this prior. And if the patient strongly wants to be off anticoagulation, I think it's hard to argue that they should remain on anticoagulation. Yes, I'd like to see a study like this one take the next step and use the actual watch-derived data, not just simulation from the loop recorder. But this is strongly suggestive that watch data can be carefully used in the AFib clinic. Okay, so one preview for next week is that JAMA Cardiology has published 2 RCTs of conduction system pacing versus biventricular pacing. The trials have discordant findings, and I will delve deeper and cover this next week, though I would say don't worry too much because both of these trials were very small, and I think the CSP versus BIV pacing story is not even close to being told yet. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. This helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.